focus of this talk is therapy studies and their critical appraisal. Specifically, the objectives are to go over various tools used to perform a critical appraisal, and then specifically the hierarchy of evidence and the PEDRO Scale, and then go through a list of questions that we use to evaluate the application of the Article 2 clinical practice. So concretely, what's expected of you after this is done is you should be able to take a PICO question and recognize it as a therapy question and not a diagnosis or prognosis question, to perform a critical appraisal using the PEDRO Scale and recognize that the PEDRO Scale really is only applicable to RCTs. Other lower level therapy studies it doesn't really apply to. And then given a kind of an abstract from a journal, be able to tell from the abstract that it's likely a therapy study and approximately whether it's a low or high level study. And then argue ways to use lower levels of evidence to support practice. So here we see the hierarchy of evidence for therapy, and we notice that we have that same leveling where we have 1s to 5s on the first column, and then all of this detail and how to grade those in the second column. But if we try to narrow some and filter out some of the detail, we can see study designs first. And we can see in a 1B, we can see RCT, which stands for Randomized Controlled Trial. And then we can go to 2B, and we can see something called a cohort study there. And then we go to a 3B, we see a case control. We go to 4, and we see a case series. And so here, in this category, what we're noticing is that pretty much every level is decided by our study design. And that would be the topic of a previous presentation. But we can understand that the study designs matter a lot in the therapy category, much more so than some of the other categories and types of questions. And really the gold standard is the randomized controlled trial. And so most of this discussion is going to be about the randomized controlled trial. And one of the key instruments or tools we can use to evaluate weight one randomized controlled trial against another is something called the PEDRO Scale. And the PEDRO Scale really helps us address 2 of the 3 of our important questions that we ask whenever we're facing off with a study. The first question, are the results of this study going to be valid, that are purely based on the methods? And then what are the results? And the PEDRO Scales helps us with both of those questions, but doesn't really, except for one of the questions, doesn't really help us too much with the third question is, can I apply this important randomized controlled trial to my patients? So let's start with the case scenario. So our case scenario is we have a 45-year-old runner. He presents with intermittent Achilles tendon pain, approximately 6 centimeters proximal from the insertion, and he has pain into the run, and then it subsides after 60 minutes. So this is kind of a typical non-insertional Achilles tendinopathy. There's a lot of these injuries in individuals that take up running or that have been running for a long time. Approximately 10% of all novice runners will have Achilles tendinopathy after their first training sessions preparing for their run. And the question becomes is what intensity of exercise to put them through, because they're running already, but the key treatment for Achilles tendinopathy is eccentric exercise. And so how far should you push them? You could either provoke pain when you ask them to perform the eccentric exercise, rationalizing that they're going to do intense exercise during running anyway, or you could try to stay below the pain threshold, rationalizing that you don't want to aggravate the inflammation and persist with an injury that's already existing. So our PICO from is individuals with mid-portion Achilles tendinopathy, and our comparison is high-intensity eccentric exercise into pain, and then in contrast to less intensity. And then our outcome measures would be a pain severity scale, like the VAS, visual analog scale, or a functional scale, like something like the VISA-A that's made specifically for people with Achilles tendinopathy. So we search online and we find this article, Effectiveness of the Alfredson Protocol, which is specifically an eccentric exercise protocol for people with Achilles tendinopathy. And they're comparing 2 intensities of the protocol in this randomized controlled trial. And we can, to kind of just understand exactly what the article's about, we can look at the purpose statement, which is at the end of the introduction. We can read it. Therefore, the objective of this study was to compare the effectiveness of the Alfredson eccentric exercise protocol with that of a modified protocol that allows participants to perform the exercise within their tolerance. So basically, we have the Alfredson protocol, which is very strict, has a very high set of standards relative to the type of intervention that's being used, and then some kind of lesser version of that that's modified. And we notice in this particular statement that as we continue reading that we have the independent variables, or the I and the C of the PICO, identified in the purpose statement, but we really don't have any information about the outcomes. We don't know what's being used to assess whether one protocol is better than another. And so the outcome variable or the dependent variable is missing in this particular purpose statement. But overall, this looks like a good paper. It's probably a randomized controlled trial. So say they're going to be a 1B or a 2B. We need to critique more to kind of figure that out. And essentially, there's these two protocols. They pertain to a really important clinical question that would help me manage my patients. And then the outcome variables, as you read in the article, you find their pain scales and function. They're very client-centered, and so the idea is that they're not going to give you something about theory, but rather about the actual management of those patients. And so it's looking really positive for this being an article that will, if valid, will really change my practice. So a good choice for this particular article would be something like the PEDRO Scale, which is designed to critique randomized controlled trials, but it's not really that useful for case series studies, and we'll talk more about that in the previous lecture. So the first item on the PEDRO Scale is eligibility criteria were specified. And what this item is really about is interesting. It's the one item on the whole scale that applies to the application question, not really validity or what are the results. And it distinguishes between external validity and internal validity. And the external validity of a study is really about what does it apply to. So is it valid to apply it to what external reference or patient group? Where internal validity has to do with what we've been really focusing on, which is does the paper have a fatal flaw, or is it really substantial in establishing the comparison between the intervention and the control, or the I and the C and the PICO? And we can see here is this is really asking us what the eligibility criteria were, so we would know what the results will apply to. So what people or individuals will the results apply to? And so what you use what you're going to look for in the paper to understand its external validity is the inclusion and exclusion criteria. And basically, the more criteria they have, the more homogeneous the group, and the more specific the application to a patient. And so we can see here the inclusion criteria are people, adults that have non-acute symptoms, so they're either subacute or chronic, and they have specifically mid-portion Achilles tendinopathy, there's another form of it that's at the insertion, and that's different because it affects different people. The runners don't typically get it, and it's associated with some bony abnormalities on the calcaneus. And so essentially these are all important characteristics, and suggests that we should only apply it to this patient group. There's a whole lot of exclusion criteria. We can see the first one here. The insertion point is meant to rule out the insertional tendinopathy. There's some other kind of diagnoses that can be misrepresented or present with heel pain that aren't really Achilles tendinopathy. They're ruled out. So essentially we have this criteria is satisfied based on a fairly sound set of inclusion and exclusion criteria. So we would use this when interpreting this and applying it to patients. So now the second item on the PEDRO Scale does apply to the validity question, the internal validity question that we've learned to ask in this class. And so essentially were the patients randomly allocated to groups? And really the random allocation ensures that the treatment and control groups are comparable. And that's really the key. and what we discussed in terms of design, it makes them comparable on both known and unknown prognostic factors. That's the key. And so here's the example from the study that we chose. We have our Achilles study here, and in the very first sentence of the methods, it spells out that the present study was a prospective outcomes assessor blinded and statistician blinded randomized clinical trial evaluating participants over a period of 6 weeks. So it's clear that they were randomized into the groups. And here's participants randomly allocated to 2 groups, both of which were taught the Alfredson eccentric exercise protocol. Okay, so we can already know that randomization was part of this study so that it would satisfy that criteria. The third criteria has to do with allocation, and so how the patients were assigned to the groups. And something called allocation was concealed. So this is not as obvious, and we'll kind of go through why it's here, and then discuss it as we move along. So essentially, it's when the person who determined if a subject was eligible for inclusion in the trial was unaware. So when this decision was made of which group the subject would be allocated to. So it has to the person who determined if a subject was eligible is the person that's applying the inclusion exclusion criteria. So essentially it's the person who's saying, okay, you're in the study. That person can't know which group they're going to be assigned to, and then the group assignment has to be done free of their choice. So what turns out to be true is that people that screen people for randomized controlled trials usually have a bias of which treatment they think that the subjects will benefit from, either the control or the intervention. And so it's been documented in many examples where people have flipped a coin, and somebody then said they went into say, like in this case, the Alfredson protocol group, and they didn't believe in it themselves. They thought that was going to be not optimal for that person. So basically they'd flip the coin again until they got the answer that they thought would be the best for the patient. And by doing that, they've kind of defeated the whole point of the randomization. So concealment of allocation is trying to deal with this tendency for people who are assigning people to the groups to do it based on some kind of indicator, clinical indicator that they think that they might do better in one group or the other. So the fourth item is groups are similar at baseline. And so essentially if the two, a randomized controlled trial is very similar to a race. You have two people with two groups of people that have the same problem. And the idea is that in terms of severity, pain, functional loss, other prognostic factors and unknown factors, that they're fairly equivalent before either treatment gets assigned to them or started on them. And once the treatments are started, then it becomes like a race. It's like which treatment gets them better and which treatment gets them better more, right? And so you're looking for one treatment to have a better outcome than another. And so the whole design of the experiment is defeated if at the baseline one of the arms of the randomized controlled trial has an advantage over the other. So essentially it's like giving one group a head start. And so essentially what you want to do is have baseline measures that compare the two groups based on criteria that aren't being evaluated in the study itself. And so it suggests, like one suggestion for the PEDRO scale is that baseline measures of severity and outcome suggest equivalence of baseline. So the criteria is that there's at least one measure of severity, and then there's at least one key outcome that's compared at baseline. And if it's a prognostic factor, it's even better, because we know that prognostic factors are factors that are statistically associated with progress or outcome in that patient group. So here's the example from the Achilles study. We can see there's a table 1, and what you want to learn is in all randomized controlled trial there's a table 1, and table 1 is always 90% of the time a comparison of baseline characteristics of the two arms of the randomized controlled trial. And we see just that example here where the table 1, it's even labeled baseline demographics and clinical characteristics of participants. And we can see things like age, body weight, height, mass, duration of symptoms, men, and active or sedentary lifestyles. And we have this comparison here. Now, Now, what we could look for those on the PEDRO, it says look specifically for an indicator of severity and or a key outcome. And what we don't really see that here. The one item that might be considered severity is like duration of symptoms. So that could pass. Now, if we look at that, there is actually a difference. We have the standard volume or the standard Alfredson protocol group has less severity. They have a 6.2 months of symptoms, where the other group has 9. That's almost a 33% increase, or 50% increase, depending on how you calculate it. It's twice as high as this. So essentially, that could be an important difference as we look at the study. But so this is made up a little bit by the fact that there are pain and other variables that we'll see in a minute that are comparable at baseline if we look at other tables. Okay, so in this particular study, in table 1, they don't have a good measure of severity, but in terms of pain and function that are listed in a separate table, they're fairly comparable. So there's some question about whether or not the baseline characteristics are equivalent, but likely for this condition, they're equivalent enough. Then the next 3 items on the PEDRO scale have to do with blinding. And so 5 is about blinding of patients, 6 is about blinding of therapists, and 7 is about blinding of assessors. And what I'd like to do is I think it's kind of obvious that biases from each perspective could be important. If the patients know that they're in the control group and not getting the experimental treatment, they could become discouraged. If the therapists know which treatment is not optimal, they may inadvertently discourage patients from performing as well and be more excited about the intervention treatment. And if the assessor knows which person was in the control group or the experimental group when they're doing the planned intermittent assessments throughout the clinical trial, they could also bias the results. So there's no question that blinding is important, but I'd like to diverge for a minute and talk about just some of the powerful Hawthorne or placebo effects. That would be the other synonym for Hawthorne effects, is same as placebo. And how blinding helps us with that some. So let's just give some examples of the strength of placebo effects. So there's some studies that we'll go through. So there's been studies where they've taken people and given them all the people painful narcotic painkillers that are unequivocally known to decrease pain. And then when they gave them to them, though, they split them into 3 groups. One group, they gave a lot of positive information about how strong the painkillers were, how effective they are, how they're going to have a strong effect if they take them, things like that. Then they told another group that they could take them if they wanted, but they don't help a lot of people. And there's maybe, they could say, like, you could become addicted to them, things like this, but they might help. Right, and then they just gave a group and didn't say anything to them. And it's amazing, the findings. The positive group, essentially, the effect of pain reduction was almost double, not saying anything. And in the case of the negative expectations, the effectiveness of the drug was almost 0. And so the power of suggestion in this case was quite significant. They did another study where they talked to people about different side effects, and that includes not just a drug but acupuncture. And in this case, they talked to people about the potential for things like physiologic symptoms like dry mouth, fatigue, and sleepiness. And in fact, the same kind of pattern was induced, where people, when they talked to them about the potential for these side effects and told them that they might experience them versus if they didn't tell them anything, then the people in the group that they talked to the side effects about all had these side effects at much higher rates than the people who they didn't present these to. And they've even done things like where they do what they call a kind of a switching thing, where they start someone on narcotics and then they replace the narcotic pills about halfway through the treatment with placebos. And in fact, what would happen is the effect of the narcotics lasts throughout the placebo application when they do these types of experiments. So it'd be like, so let's say you take a week of narcotics, and then they have some kind of pain reduction, and then you replace the narcotics with placebo, and you continue the treatment for a week. You get almost the same effect on pain reduction as if you had given them the actual narcotic. And so that's about pain, but then you also can take something like a physiologic response like anti-hypertension drugs, and you get nearly the same effect when you do the same type of protocol. So there's other types of studies that have looked at a firm diagnosis versus a vague diagnosis. So people who were giving firm diagnoses, like you'll be better, you have the flu, you'll be better in 2 or 3 days, go home and drink lots of liquids, this kind of thing. Versus people who you told, well, I'm not really sure what it is, but kind of wait and see, and come back to me in a week. So the people who were giving vague diagnoses did much less well, had continued symptoms and problems versus the people who had a firm diagnosis. And that's all coupled with studies of brain chemistry, where they would take people who had these kinds of problems, some type of sickness, and then they'd tell them, right after something about their disease, and take things that might help them, but they don't have any kind of chemical effect. And immediately they can record using functional MRI changes in brain chemistry. So the idea is that these placebo effects are actually physiologic, that are being triggered by emotions and things like this that we tend to classify as psychological. All right, and I would say functionally, what's interesting is the story I like. I mean, there's many stories about placebo effects, and the one I kind of would leave you with on this discussion is last time I looked into these types of studies, is there was a study that had to do with deep brain stimulation, and they actually made small cuts in the skull of the person, and some of them they implanted deep brain stimulators, and others of them they just told them that they had implanted a deep brain stimulator and made a scar on their skull. They also, the population, I should tell you, were people with specific types of Parkinson's disease, and so they had fairly significant functional limitations. Okay, and then they hid of course, who had this is a double-blind study where nobody knew what they were getting, and then when they revealed who was in the control and who was in the intervention group, there was people in the control group who had testimonials that they had started doing things like hiking mountains, riding bicycles, and things like this as a result of the deep brain stimulation. And in fact, they were in the control group and had received a placebo scar on their skull, and there was absolutely no insertion of a stimulator in their brains. So the point is that the effects, these placebo effects, are real. They exist in your treatments when you face off against patients, and there's something that's very difficult for you as a clinician to differentiate between when someone's actually experiencing a placebo effect and when somebody's actually getting better physically because of the things you're doing with them. So the next item on the PEDRO scale is the attrition rate. And usually these days, almost all clinical trials have a flow chart that's included as part of the report, and it'll kind of detail the attrition rate. And there's attrition in clinical trials is difficult to avoid. It's very rare that a clinical trial will have perfect attendance throughout, so there's always some attrition. And so the cutoff, an acceptable cutoff, is around 85%. So greater than 15% attrition. Okay, so you have to have at least 85% participate. You start to question whether the randomization's been supported with that kind of a loss in participation. The other thing it kind of indicates, if you're starting to get into 30%, 20% attrition rates, it's really questioning the structure of the clinical trial, whether it was executed well by the people administering it. Did they have good support? Did the patients, were they able to participate as they should? Are the treatments really taking care of them? Why is the dropout starting to hit levels that would disturb you if you were using that kind of treatment in the clinic? So that's kind of what the 85% comes from. So we look at our Achilles study. Here's an example of the flow chart, and we can see here that they start with a lot of patients. Many get excluded, so there's 28 left. They get randomized to the two groups. And then we can see that at week 3, they lost one person in each group. And then at week 6, 3 people in the Alfredson protocol group, the higher intensity group, dropped out, and then 1 in week 6 at the other. So this is like a pretty close to about a typical trial. So because the sample is so small in this case, the attrition rate's a little higher. But I mean, I would be surprised if that was perfect. And so to me, this is about a normal attrition rate. So 9 is about more about how if the actual treatments that were intended for the participants is what they received, and so it's they received treatments or controlled treatments as allocated, and this is something called an intention to treat analysis or an intention to treat evaluation. So essentially, the two arms of the randomized controlled trial both have protocols associated with them. And when there's a protocol violation, so say somebody in the control group takes up running, or someone in the control group takes up another exercise program, or someone in the control group starts doing higher intensity eccentric exercise, in the case of the Achilles tendon study, that would be a protocol violation, right? But what what can happen is you can get some. Before EBP, you would be reading a study and they'd say, well, after the study, we kept track of what people were doing, and if they did protocol violations, we switched groups. So you'd have some people that were assigned to the control group that then started doing their own thing, kind of, and so they'd put them in the intervention group because they'd say, hey, that's like the intervention, And so there was some logic to that, but in essence, it kind of what it did is it defeated the randomization. It made the study results kind of complex. And so, and stepping back from when EBP came around, it said, well, really we should treat these people as we would if we were in the clinic, because it's really a clinical trial that we're doing. So if we intended to treat them and we do it in intention to treat analysis, we should replicate the way that we would behave in a clinical situation, which would mean we give them a treatment, and that's what they would do. And if they coupled the treatment with other things they were doing on the side, or it was hard for them to cooperate, well, that is the reality of what we would experience if we were to do the treatment as well. And so essentially they're arguing that an intention to treat analysis, by keeping people in the treatments that they were originally, the groups that they were originally allocated to be in, is the best way to go. And if you're kind of crossing people over, that's just making it confusing for everybody. And even to the point where they suggest that we analyze the data by including people that drop out. So like if a person drops out at six weeks, we use his data from 3 weeks and we put it in at 6 weeks. Essentially, what we're doing there is if you're going to treat the people in the clinic with this approach, it's calculating in the missing appointments that you would have for that person as a way of taking into account the cost of doing that treatment. So their cooperation and participation and ability to come for the evaluations, do the treatments, and all that kind of thing should be part of the protocol when you're evaluating a treatment and a randomized controlled trial such as this. So here we have in the Achilles study as an example where data were missing in 21.4% of the participants, accounting for about 6% of the data. And so what that means is that makes sense at some level, because basically they had 3 different treatment points. And so at some point in time, about a fifth of the patients had some part of their data missing. So basically, they performed 2 types of analysis. They did a per protocol analysis, and that meant they just did people who followed the protocol, and then they did another analysis completely separate where they did an ITT, or an intention to treat analysis. And so that's where they, irrespective of whether people followed the protocol, they kept them in their same groups, and then they ran an analysis with them in those groups. And this is what some of you might have thought, well, if they don't participate, they're not compliant, it'd be nice to know the ones that were compliant, how they came out. So the per protocol analysis gives you that result, and then the intention to treat analysis gives you the result of just everybody together. And so by looking at the difference between the two, you can kind of tell what the effect of compliance and those kinds of things were. So now that's the end of the questions about, is the study valid? So basically, if they get all of those right, so remember question 1 had to do with application, so questions 2 through 9 have to do with the actual validity of the study, and so now we're getting into the results. So they have you ask 2 questions really about results, and so we're going to go through those now. So the next 2 questions address the idea is what are the results. So number 10 is between groups. There's between group statistics on at least one key outcome. And so let's look at that as an example for the randomized controlled trial with Achilles tendinopathy. The 2 treatment arms here are the standard and do as tolerated. So this is the standard eccentric exercise is the Alfredson protocol, and then the do as tolerated is the protocol where they just modify it so it's a little less intense. Okay, and so the Visa A is a questionnaire that they can give people with Achilles tendinopathy that's been found reliable and valid in previous measurement studies. And so if we look here, we can see that there's 3 time points. There's a baseline, a week 3, and a week 6. And we have just the description of the values here at the top. And we're going to skip this section here right now. We're going to go right down to the bottom, and this is the between group differences in change scores. So basically, this is 17.7 is essentially 2 things. It's the difference between these 2 time points and these 2 time points, and then so that's what we see here. So 8.6, 9.1. So basically, the standard group, they got their VSA score went down by 8.6, and then the do as tolerated group, their score went up by 9.1. So the 17.7 is the difference between these 2, and so essentially that's the comparison between the 2 arms. So between group means between the 2 arms of the study, and so we can look at this and we see that there's a 17.7 difference between the 2 arms, and in fact they're going in opposite directions, and a lower score in the Visa A means the people are worse, and then the higher score means they're getting better. So in effect, the standard protocol that we're using actually made people worse at 3 weeks, and the do as tolerated, the modified one, made them better at 3 weeks. So now we have this big difference of 17 points on the Visa A. So we say, okay, and then we see this confidence interval of 6.2 to 29.1. And then we see the statistical result here. Okay, so obviously the p-value is less than 0.05, so we know that it's significant. All right, so we have a couple questions though. This 17.7 looks fairly big, and we know it's significant, but we also want to ask the question, is it clinically significant? So because we know that statistical significance doesn't always equal clinical significance. So how can we judge whether it's statistically, clinically significant as well as statistically significant? Okay, so essentially what we need to do is use the MCID. So essentially what we need to do is use the MCID. We know that for the Visa A, their MCID is equal to 15 points. So what we could decide is that if something's statistically significant and it exceeds an MCID, then we know for sure that it's clinically meaningful, that a majority of the patients experienced a benefit that was beyond a minimal clinically important difference. And so if we look here, we can see that the do as tolerated group scored 17.7 points higher the standard group, and so that they clearly, if we were treating them, we would notice that they experienced a minimally clinically important difference beyond error. And so clearly this is both statistically meaningful and clinically meaningful. If we switch gears now and look at the same number for the Visa A on the between group comparisons for the 6-week baseline to 6-week comparison, what we can see is that the do as tolerated group actually does about 6.3 points better. It's not statistically significant, and it's also not clinically meaningful. So this 6.3 difference is below an MCID, and so we know as well that is not clinically meaningful. So that's how you would apply the MCID to these kind of group statistical processes. Okay, so once that's done, then the second part is to evaluate point measures and measures of variability. So what we were just doing there in that previous example was evaluating the point measures. So we were looking at the actual values that were given, but of the Visa A. And so now what we want to do is examine its variability. And so essentially this chart is going to help us just conceptually get around the idea of variability and how that works when we're looking at a clinical trial like this. And so what we've done is plotted several different theoretical clinical trials. So we're kind of just doing this conceptually first. So these are all separate studies. We can see that the study it just is arbitrary. It's A, B, C. This study has 44 people. It has 20, 35, 40, 48. Okay, and they all have different inclusion-exclusion criteria. So the severity of the samples are slightly different. Where they draw from, the populations that they draw from is slightly different. Okay, and so they all have these samples that have widely varying confidence intervals and widely varying means. So we see them here. Now, the theoretical true mean is here. It's this dotted line. So we know that that's like the actual number. We can never measure that, but we know it's somewhere in here, right? And so what we can see is that essentially there's some benefit to this treatment, obviously, here, right? But then this is the effect of 0, so there's no effect. So we're favoring two groups. So if like the 17-point favored the treatment, so in this case we're favoring the do as tolerated, it would lean over this way, 17 points. If we favored the control, it would go this way, okay, some number of points, right? So in this case, we're favoring the treatment or the intervention group, and we can see that gives us a point estimate. So the point estimate is the average of the group number or the change score, so 17.7 in the case of the VCA a minute ago, or from the 3-week comparison, or 6 in the case of the 6-week comparison. And so if we look here, though, what we can see is, so that covers like the mean or the point estimate, but we also see that there's this wide variation in confidence intervals. And so, we can notice is that like some cases the mean is accurate, but this looks like if we had this particular study, we wouldn't even know we would say it's not significant because basically it crosses 0. So the confidence interval includes no effect as well as a big, huge effect over here. Now these studies have wider confidence intervals, but they don't include a no effect, right? So this study's not significant, this study's not significant, this study's not significant, and all these other ones are. Okay, and they're not significant because it's unclear whether the mean or point estimate here excludes the no effect of the treatment. Okay, and so this is the conceptualization of what we're going to do next, right? So what we can use is we can use confidence intervals to kind of make this judgment about how precise or accurate our samples are in determining these treatment effects. And so it might help us to kind of understand a little bit about what goes into narrowing a confidence interval. So confidence intervals are numbers, and so basically they just get calculated when we do the study, but what determines their width has to do with what subjects get into the study in the first place. So if they're not homogeneous, or if the groups are heterogeneous, what that's going to do is it's going to create larger confidence intervals. So think about it this way. If we have people with really severe disease in the study, and we also have people with very low levels of the disease in the study, what it means is that the potential is that people will react differently. More severe people will take longer to recover. They may not have as big a treatment effects because they have a lot of pain, disability, swelling, things like that, where people with chronicity may do better, or it may even be flipped. But the idea is that there's not much homogeneity on severity. There may also be important prognostic factors that are comorbidities that may make people get better slower. So, for example, if they're older, or if they have diabetes, or if they have some kind of nutritional deficit, okay, some prognostic factors are more important than others. But if the people aren't homogeneous on prognostic factors and severity, that alone could cause a large range of differences in how much people respond to treatments. Okay, and the other part may have to, so that's one thing, and that's usually the biggest thing, is how the sample was determined, like what factors controlled the sample. And notice in this case, what's better is a homogeneous sample, not a heterogeneous sample. And so the other thing that comes into play is the measurements themselves. Are they good? Is the dependent variable being used? Is it very reliable? Is it rigorous? And then the final thing that determines it is sample size. So let's look at the Achilles study. So they attempted to achieve, the strategy to achieve a narrow confidence interval was that they used reliable and valid measures. Both the VSA and pain scores are well established. They had a lot of eligibility criteria, so they were trying to drive up homogeneity by controlling the sample, like 3 inclusion, 7 exclusion criteria. But that came at a cost by driving up their inclusion-exclusion criteria that made it more difficult for them to recruit, and then their sample size suffers. So that was a negative. So they tried to control it by using good measures and achieving homogeneity on the inclusion-exclusion criteria, but they didn't achieve an adequate sample size, and so that hurt them a little bit. So we have to do now, so their confidence intervals are what they are now that they've done the study. So then now we have to decide if they're narrow or wide. And if they have wide confidence intervals, we're going to rank the study, we're going to not immediately knock it down to a 2B from a 1B if it's an RCT. And so we have to have a definition of what a narrow confidence interval is so we can rank it as a 1 or a 1B or a 2B. So we first have to understand errors. So type 1 error is when we find that the intervention is significant when it's not really significant. So we made an error on the favor of saying the treatment really works when it really doesn't. A type 2 error is the opposite, when we say that they find that the intervention is not effective when it actually is effective. So both types of errors can occur, and the confidence intervals help us figure out the possibility of one of these types of errors. So what we're going to say is that a narrow or wide confidence interval means that we can't rule out the possibility of one of these types of errors, either a type 1 or a type 2 error. So let's look at how this works, applying it to this sample. So example, so we have our Achilles tendon results here, and we go back to that same between group differences that we were looking at a few minutes ago, and we notice that the VISA-A at 3 weeks has a point estimate of 17.7 on the VISA-A. We also notice that the confidence interval varies from 6.2 to 29.1. And then we also know that the minimal clinically important difference is 15. All right, so let's see, and we also said that below 15 we would decide that there's no real difference between the two treatments in terms of clinical significance. And so we can look at the confidence interval and say, okay, we're saying it's significant. So in this case, for it to be conclusive, or for the confidence interval to be narrow enough for us to rank it as a 1B, we need the confidence interval to exclude the possibility of values, point estimates lower than 15. And in fact, that's not true. The possibility is that the point estimates could vary between 6.2 and 29.1. It doesn't exclude a possibility of a response that's less than a minimally clinically important difference, and therefore we would rank this particular finding as a 2B. And so let's look here and apply it in the opposite direction. So here we have the 6-week comparison for the Visa A, and we notice that the 6.3 point estimate has a confidence interval from minus 3.6 to 16.1. And so we're saying here it's not significant. So now we have a chance of a type 2 error, and we can say, all right, let's see if this could be as high as 15, because if it can be as high as 15, then we know that it's possible that a type 2 error was made in this study. And so we look at this here, and we can see that the confidence interval is wide enough that it includes the possibility of a 15-point change given a larger sample or a more homogeneous group or something like that would narrow the confidence interval. And so essentially this is not conclusive. So this estimate here at 6.3, the confidence interval includes the possibility of an actual change that is significant. So this finding also would get a 2B ranking. So the confidence intervals, at least for this particular one, are too wide. Okay, and this is spelt out here in detail. So if you can work through this on your own, you can see here's the Visa A score of 17.7. The confidence interval is significant, but we have a chance of a type 1 error, so we want to see what that possibility is. So we're looking to see if this excludes the chance of there being no significance. So we're looking at the lower end here. For this particular example, the confidence interval includes the possibility of an effect smaller than 15 points in the Visa A, so we would say that this confidence interval is too wide. And then we could work through the same logic here for a type 2 error. Okay, so we've essentially examined this study. We understand that it's valid, but that the confidence intervals are too wide in the results, and so it's not conclusive. However, that leaves it at a 2B ranking, so it's quite good, but not ultimately conclusive. And so now what we need to do is see how we would apply this to patient care. And so essentially when we're applying it to patient care, we have some questions that we could ask, and we could say, is the treatment available, affordable? Is it just essentially practical to deliver in the clinic? And this is really the second item is the question 1 on the PEDRO scale. It's asking, were these similar to my patients? Will I see patients similar to this in my clinic? So is it just a direct transfer from the study results to my patients, and I can expect them to behave the same way? And then the third question has to do with, is this a really risky treatment? I mean, is there a possibility of harm? So for example, in Achilles tendinopathy, is it possible that they could rupture their tendons, like working into pain and loading them up really high? Is it possible that we could hurt them? And then the fourth question is, will the patients relate to the treatment, or will they accept it as an approach? So if it's too aggressive and they have a lot of pain, the idea is they probably wouldn't participate. So if we use those criteria and apply it to our case with Achilles tendinopathy, we can see that, is the treatment available and affordable in the clinic? Well, sure, it's pretty easy to do. Can it be applied to my patient? The study sample is very common, and you see those patients all the time. They have about the same severity of the disease, and so it's a direct application. Do the potential benefits outweigh the risks? So there is some harm, with doing 180 reps and the pain that they'd have. So you'd have to develop a pain model to deal with it. But can you do that using the VAS and different strategies? Yeah, you can. And what's the potential benefit? Well, it's a very difficult problem to treat, and so it's possible that pushing them into that may be helpful. So clinical bottom line, would you use the do as tolerated dosage for eccentric exercise? Clearly, the do as tolerated dosage was 17 points better at 3 weeks than the other, and even though it's not conclusive, it's better than making them worse. And the Alfredson protocol actually made them worse at the 3-week point, where the do as tolerated, they got better, and at 6 weeks they were the same or better in the do as tolerated group. So there's enough evidence here to just go ahead and adopt the do as tolerated group, even though it's not absolutely conclusive at a rigorous EBP level. So that's the critical appraisal for this study. It's we've answered the 3 questions. Are the results valid? What are the results, and how does this help me with my patients? This is an example of how you would apply the PEDRO scale and the different criteria used. And you should be happy on the porch after you're done with all that hard work. Okay, thank you.